Hi everyone, my name is Marisha Johnson, and today I'll be presenting my work on predicting ICU mortality using first 24-hour clinical data. Before getting into the results, I want to briefly talk about how I got here. I first started this project by reviewing existing literature on ICU mortality prediction and learning about different machine learning algorithms. Along the way, I also studied evaluation metrics, as well as data preprocessing and visualization techniques. And at the same time, I began working with the PEMACS dataset, which is a large real-world ICU database. That work is what led to the analysis that I'll be presenting today. So overall, this presentation will focus on how machine learning models can be used to predict ICU mortality early using only the first 24 hours of patient data. Early identification of high-risk ICU patients is extremely important. It allows for timely clinical intervention, better allocation of hospital resources, and more personalized treatment strategies for patients. Traditional approaches often rely on delayed or aggregated data, which limits early decision making. However, with the availability of large datasets like PEMACS machine learning allows us to make accurate predictions much earlier within just the first 24 hours. Currently, clinicians use scoring systems like Apache 2 and SOFA. While these are useful, they have several limitations. They rely on linear models, require manual calculation, don't capture complex relationships between variables very well, and they also don't generalize perfectly across the different patient populations. Because of these limitations, there is a need for more automated, scalable, and accurate approaches. This is where machine learning comes in. So for this study, I used the PEMACS dataset from PhysioNet. To be able to view this data, I had to get a certification called the Biomedical Responsible Conduct of Research Certificate. This dataset originally included over 70,000 ICU patients with a mortality rate of about 7.5% and an average age of 64. One interesting insight is that the highest mortality rate was seen in the neurosurgical ICU at about 12.9%. I applied several inclusion criteria to focus on the dataset. I only included adults between ages 18 and 90 years old. I included only the first ICU admission because I didn't want to include duplicate admissions of the same person. And then I also removed the stays that were shorter than 4 hours because there wouldn't be enough information provided in a stay that was shorter than 4 hours. The features included demographics, ICU subtype, and lab values collected within the first 24 hours. And so the selected features shown are typically the tests that are ran within the first 24 hours of admission, which were lactate, blood urea nitrogen, or in this presentation I will refer to it as BUN, creatinine, sodium, potassium, chloride, glucose, white blood cell count, hemoglobin, alanine, aminotransferase, and platelets. And then the different ICU subtypes that are included were medical, surgical, cardiac, and neurological, and other. And then this slide is just a visualization of the final cohort after the pre-processing and applying all inclusion criteria. So you can see that after applying all the inclusion criteria, the data set went down to 50,827. Prior to my research, I also looked at multiple different studies that worked with the same data set, but in this presentation, I'll go over two. First was a heart failure mortality prediction on PEMACS, and the second one was machine learning prediction of ICU mortality. Across both studies, XGBoost consistently performed the best. For example, one study achieved an AUC of 0.82 using first 24-hour data, while another achieved 0.743 using a broader set of data. It was a broader set of data because in the first data set, they only focused on patients who had heart failure, which is also why they used a 70-30 test split because their data set was just smaller. And some common important predictors included age and clinical severity markers. These findings helped guide my model selection and expectations for performance. So I trained on four different models, which were logistic regression, random forest, XGBoost, and LightGBM, all trained on an 80-20 train test split, with class unbalance handled through weighting and hyperparameter tuning. These models were evaluated using AURC and AUPRC, AUROC serving as the primary measure, which helped the model distinguish between high risk and low risk patients. While AUPRC is especially useful when dealing with imbalanced data sets like this one, overall gradient boosting models, XGBoost and LightGBM perform the best. They exceeded the clinical usability threshold of 0.70. All three of the models did, besides random forest, which performed the poorest. I would say logistic regression, like GBM and XGBoost, all performed pretty well because they all performed above a zero point 0.8, and the threshold was a 0.7. In the graph to the right, you can see that it's looking at the model scores by each subtype, and they all kind of fit the same depending on the different subtypes. And you can see where random forest falls below the threshold of 0.7. You can also see kind of a dashboard of the different AUROC scores for each model on the bottom. And on the top is the confusion matrix, which is really important to focus on false negatives. And in this case, a false negative would mean incorrectly predicting a patient to be low risk when they're actually at a high risk for mortality. So we'd want the algorithm that would best predict as few incorrect low risk patients as possible, which is very important for a clinical setting. And when looking at all of the algorithms, XGBoost does the best at this job with only 176 false negatives compared to Random Forest, which had 926 false negatives. This is clearly a big difference and significantly can show that XGBoost is more reliable for clinical use. To better understand the model, I used SHAP analysis on the XGBoost model as it performed the best. The top predictors found were age, BUN, and cardiac ICU admission. We also see that higher lactate levels are strongly associated with increased mortality risk. Here, I'm just going more into depth on the top three predictors for the SHAP analysis. So starting with age, which is the graph all the way to the left, as mortality risk increases linearly, it will increase linearly after about age 50. For the middle graph, which is focusing on the blood urea nitrogen or BUN, the risk increases sharply up to around 25 to 30 milligrams per deciliter, and then it will kind of begin to plateau, suggesting that a possible clinical threshold, and that meaning there would be intervention once a patient's BUN reaches around 25 to 30 milligrams per deciliter. And then on the graph to the right is showing the mortality risk for cardiac ICU admission. Patients in this unit consistently show lower mortality risk compared to others that are not in the cardiac ICU admission. I also then tested these models on a completely different data set, and I chose this data set from the 2020 ICU mortality datathon by WIDS, which included about 130,000 patients globally. Again, XGBoost performed the best overall, achieving extremely high AUROC and AUPRC scores. LightGBM was also consistent, reinforcing that the gradient boosting models are the strongest overall. In conclusion, XGBoost achieved the highest performance with an AUROC score of 0.56 on the Mimic4 dataset. This shows that first 24-hour clinical data alone is sufficient for strong mortality prediction, enables practical real-time clinical decision support in an ICU setting, and additionally key predictors like lactate and BUN, blood urea nitrogen, align with real ICU physiology, supporting the validity of the model. Moving forward, I am also working on a manuscript that will compile these findings for publication, and hopefully they will be published soon once they are reviewed. Thank you for listening to my presentation, and thank you to my mentor, Dr. Al-Samani, for helping me and providing me with a lot of resources throughout this research. Thank you.